My name is Eric Hess. I'm a professor of emergency medicine at the University of Alabama at Birmingham. And this is the Chest Pain Choice Pathway Implementation Webinar, Session 1. This webinar is a product of a collaboration between the Mayo Clinic in Rochester, Minnesota and the University of Alabama at Birmingham. What I'll be discussing today was funded by the Patient-Centered Outcomes Research Institute. There are no other conflicts of interest that I have to disclose. Today we'll be talking about the why behind shared decision-making in the emergency department, what evidence supports the efficacy and the effectiveness of shared decision-making in our setting, and finally, how we plan on implementing the chest pain choice pathway in our emergency department at the University of Alabama at Birmingham. And this is meant to be a demonstration of how it might work in one setting, but keep in mind that the how might differ in your setting so that it's contextually appropriate. So let's start off with the why behind shared decision making. In his book, Anyone, Anything, Anytime, Dr. Brian Zink, who is currently Senior Associate Chair of Education and Faculty Development at the University of Michigan, describes the history of emergency medicine. In the mid-1960s, the number of specialists in the United States was rising, and the number of general physicians was declining. And as this occurred, hospitals began to require specialty certification in order to deliver care at that hospital. And subsequently, these hospitals quickly became healthcare delivery hubs. As access to outpatient physicians declined, patients began to increasingly seek hospital-based care. In 1961, 3 physicians in Alexandria, Virginia, led by Dr. James Mills, closed their outpatient office practice and began to exclusively provide care in the Alexandria Hospital Emergency Department. Known as the Alexandria Experiment, other hospitals followed suit, and similar movements occurred in other cities around the United States. Groups of emergency physicians came together and formed the American College of Emergency Physicians. But the urgent need for formal training came to a head in Cincinnati, Ohio, where over 100,000 patients crowded the Cincinnati General Hospital grounds annually. Dr. Herbert Flessa, who was in hospital leadership at that time, was told to do something about the problem in the ER, and he developed the first emergency medicine training program. Unlike other specialties, which are based on a defined knowledge base, the specialty of emergency medicine was born out of a response to a societal need to provide care for any patient, for anything, at any time. Similar to emergency medicine, shared decision-making emerged from a societal movement. This is a picture of the location of the Salzburg Global Seminar in Salzburg, Austria. This seminar was originally founded in 1947 in the wake of the devastation of World War II, when the world was questioning what it really meant to be uniquely human and what it meant to treat another individual with dignity and respect. In 1998, when discussing what it meant to treat humans with dignity and respect in the context of healthcare, Valerie Bingham was quoted as saying, "Nothing about me without me. Nothing about me without me." This call to arms fueled the shared decision-making movement. And I propose for your consideration, shares a common bond with the foundations of our specialty. Our specialty was born out of a commitment to care for any patient, anytime, anywhere, regardless of the circumstances or the ability to pay. And the shared decision-making movement is calling us to a higher standard, to when we live out this commitment, to do so in such a way that it treats each patient with dignity and respect. There are many different definitions of shared decision-making in the literature, but the definition that I find most easy to grasp and remember is involving the patient in decisions to the extent that they desire. So let's talk a little bit about the background of the clinical topic of our chest pain choice implementation pathway. Chest pain is the second most common reason patients visit emergency departments in the United States. Despite our very best efforts and advanced technology, we still miss approximately 1.5% of cases of acute coronary syndrome. And we're well aware of this, and as a consequence, we admit low-risk patients frequently for cardiac testing. When we take a low-risk population and extensively test them, the low pretest probability of disease results in many false positive test results, unnecessary procedures, and increased downstream costs. And in this whole process, if we're honest with ourselves about the decisions that we make when we're under stress and we're trying to get patients cared for quickly, we infrequently involve the patients in admission decisions. So what is the evidence behind shared decision making in our setting? This is a summary of a systematic review that has been published by Don Stacy and colleagues for several years, and the most recent iteration was in 2017. And this systematic review demonstrates that, on average, use of decision aids increases patients' knowledge about their options. It increases the perception of risk such that it is more accurate than it would have otherwise been. It decreases patients' sense of uncertainty related to feeling uninformed among their treatment options. In cases in which individuals are considering major elective surgery, for example, such as mastectomy versus lumpectomy, or for a male who's considering a prostatectomy versus localized radiation, use of decision aids to facilitate shared decision-making has been shown to decrease the frequency with which patients elect for major elective surgery. And in the case in which males are considering PSA screening to assess the risk for prostate cancer, we often will choose to undergo PSA screening less frequently when we know the advantages and disadvantages of the screening diagnostic modality. This is the decision aid that we are using in our implementation trial, and I have described elsewhere the development of this decision aid, but today I'll focus primarily on how it might be used in the encounter and to help us understand the different components of the decision aid so that we're comfortable when we're actually caring for a patient and using this to facilitate a shared decision. The first section focuses on reassuring the patient that the tests so far are negative for heart attack. And now I'm going to transition and I'll be speaking to you as if you were the patient so that when you're using this, the language will be more natural to you. So we know that based on both blood tests and an electronic tracing, the pink electronic tracing that we obtained, that you at this point have no evidence of a heart attack. If you did have a heart attack, there would be enzymes in your blood that we could detect called troponin, and this pink tracing would show evidence of decreased blood flow and oxygen to your heart. Once we have finished all the testing in the emergency department, we'll be able to say with confidence whether or not you've had a heart attack. But what we're not quite as good at is telling you your future risk for a heart attack. Do your symptoms right now represent the signs of a future heart attack? So the way that we determine this future risk is twofold. First is either a stress test or secondly a coronary CT angiogram. And a stress test will hook up electrodes to you and have you run on a treadmill and determine how it affects blood flow to your heart. And with the coronary CT, we'll be able to take pictures of the arteries to your heart to determine if there's any blockages. Now, this is your personalized risk for a major adverse cardiac event in the next 30 days. So out of every 100 patients like you, based on people of similar age, people with your gender, with your risk factors, and your test results, we know that one patient had a heart attack or pre-heart attack in the next 30 days and 99 didn't. this is the same information that I just told you, but it's shown to you in a picture form with the little red character indicating the one who had heart attack and the 99 blue characters, those who didn't. Okay, so with this background information, let's talk about what our next step might be. The first step would be to undergo either stress testing or coronary CT while you're here during your emergency department stay. The second option would be to follow up with a doctor within the next 72 hours and talk with that doctor to determine what the next steps to your evaluation might be. The third option is for you to follow up with a primary care doctor, and you can choose this option if you have a good relationship with your primary care physician, but if you choose this option, I would still feel most comfortable if you had this 72-hour follow-up as a backup. And finally, this is something that you're not ready to make the decision. Maybe you feel uncertain or anxious and you would prefer that I make the decision on your behalf. So we tested this decision aid in a single center trial in Rochester, Minnesota at the Mayo Clinic. And this trial included patients who had negative initial evaluations, that is, they had no evidence of cardiac ischemia either on ECG or troponin. Their troponin was not elevated. And these patients were being considered for admission for observation for consideration of stress testing. And so we found that patients who were randomized to the shared decision-making arm, facilitated by the decision aid arm, compared to those who were randomized to usual care, had greater knowledge about their risk for acute coronary syndrome and their management options. They were substantially more engaged in this decision by their physicians. There was a 19% lower rate of observation unit admission for stress testing. At 30 days, the rate of stress testing was 16% lower in the intervention arm. A much greater proportion of patients opted to follow up as an outpatient, and 67% of providers said they would want to use a decision aid for other types of conditions to facilitate this type of discussion with patients in the emergency department. And finally, in either arm of the study, there were no missed adverse cardiac events. So the next question we asked after completing the multicenter trial was, what is the effect of the decision aid in potentially vulnerable patients? And in order to answer this question, we assessed the impact of the decision aid on each of the outcomes that I showed you previously, but in this time we did so in specific patient subgroups. This is a forest plot which shows the effect of the decision aid in each of these patient subgroups. The 0 vertical line is the line of no effect. So if both the black dot, which is the point estimate, and the lines on either side of it, which is the 95% confidence interval, are to the right of the vertical line, then you can extrapolate that the decision aid had a positive impact on that outcome or in that subgroup. I'd like to draw your attention first to the subgroup race. So you can see that the decision aid increased knowledge significantly in both whites and non-whites, but to a relatively greater degree in whites. In addition, the decision aid increased knowledge in patients who had both typical and low numeracy. And numeracy is a measure of how well an individual uses numbers in their daily life, such as calculating a tip or interpreting a weather forecast. And here you can see that patients who had low numeracy also had significant increases in knowledge. This is the effect of the decision aid on physician trust according to patient subgroups. And I'd like to draw your attention to the variable literacy. Note here that patients who had low health literacy had relatively greater increases in physician trust compared to those who had typical literacy. So this analysis shown in this diagram as well as the diagram previously is starting to tell a story that the decision aid increases patient knowledge similarly across all subgroups, with certain subgroups having greater increases in knowledge, but that it increases physician trust in patients with low health literacy. So when you're interpreting both of these slides together, the first slide that I showed you on knowledge indicates that the use of decision aid increased the knowledge similarly across all subgroups, but certain characteristics of patients may result in greater knowledge increase than others. This slide shows that if you have low health literacy, you actually had a greater increase in physician trust. So the decision aid had a positive effect in all of these patient subgroups, but slight differences in its impact, depending on patient characteristics. Finally, how are we going to use the chest pain choice implementation pathway at the University of Alabama at Birmingham? And how are we going to incorporate the decision aid in this? This is an overview of the process that we are planning on implementing. First, there will be an electronic notification to the physician that they can see on the tracking board. If a patient has a chest pain or chest pain related complaint, if their age is at least 30 and the physician or another healthcare provider orders a troponin, then a visual reminder that a shared decision-making order needs to be placed is shown on the ED tracking board. So when physicians are, as we do each shift, are looking through each of our patients and doing internal rounds or actually discussing the rounds with our colleagues, this notification will be visible. Second thing a physician will do will be to place an order called the UED, which in this stands for University Emergency Department, ACS order, in the electronic health record. The next step will be to complete a heart score and print the decision aid. The physician will then take this printed decision aid to the bedside and engage the patient in a shared decision-making conversation at that point in time that we currently just discuss the next steps for the patient, whether it's hospital admission or discharge. Finally, the physician will place an admit or discharge order and complete their documentation. In our system, the electronic health record is Cerner, and here's an example of the order that will be placed by physicians to activate a form that will facilitate completion of the heart score and subsequent documentation. So if you type in UED_ACS, the order comes up. You click on that order, and the next thing that's displayed are each of the variables of the heart score. Our IT team has designed this such that the age and the troponin will be automatically populated, and the physician will complete the history component of the heart score, the ECG component, and the risk factor component. Once each of these radio buttons are selected, the heart score will be generated and the patient will be classified as low, moderate, or high risk. At that moment in time, another link will be available and the physician can click on it and open up the decision aid that corresponds with each of these three levels of risk, print it out, and then go to the bedside and have a discussion with the patient regards to what the next steps will be that's informed by their risk and engages other family members as appropriate. Finally, when the physician at any moment in time goes back to their clinical note, they could be interrupted for any number of reasons, but when they actually go to complete their documentation, each of the individual variables of the heart score will be incorporated in their documentation, as well as the disposition decision that was made with the patient, and currently under development is standardized verbiage regarding the discussion that was had with the patient. Thank you for your attention during this webinar and for the efforts you will make to improve care by engaging chest pain patients in their emergency care decisions.